It is September the 28th, 2018, and this is episode 2 of the official podcast of the Royal New Zealand College of Urgent Care. Coming up on this episode, to help us prepare statements and deal with forensic gathering and court appearances, we talk to the National Coordinator of Forensic Medicine for New Zealand Police. We visit the nurses' station to discuss plaster cast removal. We revisit this month's urgent bites in the email section, and we catch up with all the urgent care relevant news from New Zealand and around the world, including an extraordinary first date kiss, early sepsis detection guidelines, a nasty consequence of a rose thorn to the hand, and we look at Apple's latest watch. Right, so welcome to episode 2 of the official podcast of the Royal New Zealand College of Urgent Care. My name is Guy Melrose and I'm your host, and this week I'm joined by one co-host, Dr. David Sorrell, our Director of Clinical Training. Afraz is out overseas at the moment, so he can't be with us. So thank you for joining us again, Dave.
Thanks for inviting me.
We should say that he sounds a little echoey this time because he's on an internet connection here. We're in different parts of the country today. So the first thing we'll get to is our interview, and this week we have an interview with Dr. Jack Drummond, who is the Chief Police Doctor for New Zealand, and I sat down with him a couple of weeks ago to chat about taking statements and gathering evidence and just making sure that we do everything correctly when we have to deal with cases that involve the police or might go to court. So we will have a listen to that now and then have a chat in a minute. So I'm here with Dr. Jack Drummond, who is the National Coordinator for Forensic Medicine here in New Zealand. Jack graduated from Otago University in 1970 and has been a general practitioner since 1973 until the present day. He also worked as an anaesthetist from 1973 until 2003, when he took up working in palliative care. He's been a police medical officer since 1971, and in 2006 he became the National Coordinator for Forensic Medicine. He is a Fellow of both the Royal Australian and Royal New Zealand College of GPs, holds a Master's in Forensic Medicine from Monash University, and is a Fellow of the Royal Australasian College of Pathologists. I've asked Jack to speak to us today about dealing with cases that might go to court, how to document our notes, how best to write a statement, what mistakes we can make, what happens if we go to court, and the gathering of forensic evidence within our clinics. But first up, Jack, what does your current police role entail?
Well, my role is that I am the National Coordinator of Forensic Medicine for New Zealand Police. That is, I am employed with the task of training, peer reviewing the 68 police medical officers who are in various sites around the country. That almost every area except one that has a population of more than 21,000 will have a rostered group of police medical officers.
So in urgent care, we see people that have been involved in road traffic accidents or alleged assaults quite often. These cases sometimes require a statement at a later date. How do you advise we maintain adequate documentation, and what are the essentials that we need to document?
Well, I think you've always got to assume that each case will go to court, and of course we all know that probably that only represents about 5 or 10% of cases. And even then, in that 5 to 10% of cases, you will find that if you have written good, clear, consistent evidence, that this will often be accepted as what we call a hand-up, and you won't need to appear in court. So the better job you make of this, the less often you're ever likely to go to court. And I'll talk a little bit about court presentation later. If you are asked to examine a person, the first thing to do is to get consent. This may be verbal, but it's nice if they sign on the dotted line. But the consent has to be to examine the patient and then to divulge for your findings to New Zealand Police who brought the person in. You are entitled to make observations of a person and note those observations, and that will be accepted providing you have sufficient experience as a practitioner, as most you will have. You will be able to give evidence to the effect that while I did not do a formal examination of the suspected intoxicated person, he had red eyes, slurred speech, was unable to stand unaided, was obviously would fit in with a gross state of intoxication and would be unfit, to my mind, to be driving a motor vehicle. Now that is quite acceptable without doing all the formal examinations. You may be asked why you didn't do the formal examinations, at which stage your answer is very simple. He or she did not consent to you doing those examinations. So first of all, you've got to get the consent to examine, and then we'd go into your examination of the person. As is always with your notes, it's better to write plenty rather than a little. Write it clearly so that you understand it. If you're able to take photographs and there's consent to that, please take photographs. Photographs are really what we call an aid memoir. They are an aid to your memory, and we don't expect you to take photographs up to the hopefully ever improving standard that police photographers would take them.
So if we take photos as an aid memoir, could these be used as evidence? And what are your tips for taking photos in this context?
It could be, and you may well say, well, doesn't that lend itself to Photoshop and all sorts of things? The answer is yes, it does, but a photograph is only ever as good as the person swearing that that is what they took and that they are satisfied that that is genuine. So the value of a photograph is based upon your credibility as an individual. The tips in photography, if you are an amateur photographer, as we all are, to make sure that you have plenty of light, as little shadowing as possible, because shadowing, particularly around the neck, looks like a bruise. And if you have got cuts and bruises and the like, if you can get a tape measure and put them just adjacent to this, it gives us an idea of how to be able to describe this as a incised wound of so many millimetres. And when you describe it in a way that a lay person can understand. You can describe it medically if you like, but you must put in brackets that what a lay person would understand by the injury.
Do our photos need to have an identifier on them?
Yeah, that's very nice if you can do it, but probably it would be perfectly acceptable, since most of these are going to be an aid memoir to yourself, for you to take one scout photo, identifying photo of the individual, and then say, photograph 001, 2, 3 and 4 are of the following. But if you are in a position to take photographs and you think they are very important, then of course it's your duty to advise the police to get a police photographer to take formal photographs, and for you to indicate the areas that you think it'd be most important to take those, because they are only lay people and they don't really know what to look for in a case, for example, of strangulation, and why a person with an injury to their ankle has bruising on their toes. Well, we all know because we see it all the time, but they don't know why those things occur, and we need to lead the way there.
So how do you advise we go about writing a statement?
Well, I guess the first three rules of it are write it yourself, and write it yourself. Don't let anyone else write your statement for you. People have a habit of leaving things out. They have a habit of putting undue emphasis on some other things that you may not do. And bear in mind that in court, you are going to have to justify all those words that are on that statement. So be careful what you say, because you may well have to live with your words. And if you don't know something, put something in that just say, you don't know, and I cannot be sure of this, because if you can't be sure, you can't be sure. The layout of the statement is pretty traditionally documented. I do mine in bullet points, but you're free to do it in any way you so feel. It will be probably rehashed by the Crown, where they will do it in sentence per sentence, double space it and number it. Now that's not too bad an idea, because they can then refer you to point 47 down below and say, what did you think of that comment there? So that's fine. How do you set yourself out? Well, you start off by saying who you are, or what your full name is, or what your qualifications are, or what your experience is. Do not put abbreviations. If you're going to put abbreviations, if you put MBCHB, you put in brackets Bachelor of Medicine and Bachelor of Surgery. Then you go on to experience and comment on any other experience that you may have that may be relevant to the particular case that you're seeing. It is over to you to establish the fact that you are an expert witness. And I'll tell you a little later what an expert witness is. Having then got your credentials all laid out, the best thing I can suggest you do is that you flick it to me at some stage. I will format it for you. You send it back, and you just cut and paste it for anything you have in the future. Getting back to your format, you then, having decided who you are, and what your experience is, you then go into the examination of the patient, that is issues of consent, and then objective findings on what you found. There was bruising over the outer aspect of the left clavicle. You then say this is at the outer tip of the collarbone, and everyone then put that in brackets. Everyone understands what you're looking at. You put the dimensions of the bruise in, and then proceed to annotate exactly what you found on the person, both in anatomical and in lay terms. You then can give, if you feel you are able to, you can give an opinion on what may be the purported mechanism of these. You may say these injuries show characteristics commonly found in self-infliction, or commonly found with contact with a sharp object, for example, piece of glass, scalpel, knife, axe, that sort of thing. And then, having done that, you should then put some definitions, which I can provide for you, some definitions of what a bruise is, how you age a bruise or how you can't age a bruise, what an incised wound is, what a self-house, what are the characteristics of an abrasion, what are the characteristics of a laceration, what are the characteristics of bite marks, stab wounds, those things, and put definitions that are appropriate to your findings. So don't put all those definitions in just because someone's got one scratch across the bridge of their nose. So just pertinent findings. And then at the end you put what is called a jurat, which is a statement saying that I confirm that I'm telling the truth, and that I realise I'm committing an offence if I don't conform to this, and that's readily available on either on internet or from me. Anyone who's going to court should briefly look up once in their lifetime the High Court instructions for expert witnesses, 2015, I think it's section 3. All it really says in typical legal jargon, it really says that I am here to help the court. It does not matter who pays me. It doesn't matter who calls me. I am here to tell the truth without bias and for the clarity of this court.
What are the potential pitfalls, problems and mistakes we could come across?
I think over describing things or over interpreting things is probably where you're going to go wrong. And then when you're given an out by saying there could be other causes, you say you become pretty dogmatic about it. And you've always got to realise that there are unlikely causes of most things. But it is over to you then to emphasise to the court your view on the likelihood. And yes, an incised wound like an appendix, and I always think of an incised wound as being your first time you ever saw an appendix operation. So it's a sharp-edged wound made with a sharp object. You can safely interpret and say, no, this is not consistent with the story of falling onto the footpath. And that this is a highly unlikely scenario, and I cannot imagine how this could occur. So you have an ability to put a degree of weight on things. Similarly, you have the ability to put a degree of weight onto potential damage that you see. Now, by that I mean that a simple incised wound around the throat, which may only require 6 or 8 stitches of 3/0 nylon, actually you have a duty to describe to the court that while this has been, from a medical point of view, has been a very minor injury, from a forensic point of view it is a very serious injury. You can then draw a mental diagram for the court as to what actually lives under the lateral aspect of the neck and around that area, and say this is actually 3 millimetres away from being a fatal injury. And so it's over to you to emphasise, and this is particularly important with the new laws that have come in regarding strangulation. And we know that at least 50% of people who are strangled significantly do not have any sign of injury. And we also have a duty to the court, if we're seeing someone like this, to resist saying that because there's no sign of injury. It's similar to sexual assault. The fact there isn't any injury doesn't mean to say the person hasn't been sexually assaulted. And because there isn't any injury to your neck doesn't mean to say you haven't had a near-death experience of being choked. So again, we have a duty to give clarity and to assist the court in coming to a conclusion.
What happens when we get summoned to appear in court? Most of us only have experience from what we have seen on the television.
Well, I don't like television. That's the most important. The most important part of it is that if you are there to give good, clear evidence, you have a duty to try and make sure that gets through, and you don't let anyone alter that. the format which you go into court is that you'll be asked to come in and either swear on the Bible that you'll tell the truth, or if you take an oath of allegiance that to the Crown that you will tell the truth, either one depending on your religious views. And you then sit down. Now today you don't have to actually talk quite as slowly as we had to in the past, and you don't have to spell as many words as we had to. But in the past, the person who was the lead was the rate limiting step in court was the court stenographer. But this is not so. So you want to space yourself reasonably from the microphone, and the judge will tell you how it's coming through. He gets words from the typist pulled down below. And you'll be led through what's called your evidence in chief. And the evidence in chief is essentially your statement. Now, you are entitled to refer to your what we call your contemporaneous notes. Contemporaneous notes are notes that you make on the day in question. And you are able to refer to those, but you must ask the judge's permission to do so. That will always be granted, and you'll always be allowed to read from your statement as well. And the judge may say, just read your statement, doctor, and that will be your evidence in chief. And you may then be whoever called you, probably the prosecution, would then ask some questions and cross-examine you on them, and then the defence will then cross-examine you on on what you've had to say. The order then next is that they are asked, is there any re-examination? So any further questions may be asked, and from both sides. Usually there won't be many. And then finally the judge will ask you, he'll ask any questions that he would want clarified in his own mind, and he will explain those things to the jury as to why or he may do that in his summing up later on. One of the tricks of the trade is that when a barrister talks to you, you should reply facing the judge and the jury. It's a very uncommon situation where you don't reply to the question from the person that you reply to the question but not looking at the person that asked you the question. And it just says that you know your way around the traps. And if you don't know, say you don't know, don't let people put words into your mouth. Don't let someone say answer yes or no. Just say to the judge that, sir, I'd like to answer in a manner that would not lead this court into any erroneous conclusions. And I will always say, doctor, just explain it in your own way. It's not a frightening place to be. It's just not your domain, that's all. And we're all slightly arrogant egotists who are quite used to running our own domain and being the boss of what we're doing. And so are the lawyers who are the boss of where they are. We just happen to be in their swimming pool for a while. And you just got to make sure that you stay in the boat. Sharks are out there, and they'll get you. But never lose sight of the fact that you know a lot more medicine than they do, and even the best of them, and don't have the depth of knowledge of medicine that we have. I have a son who's a criminal barrister, so
Might we be asked to gather forensic evidence by the police in our practice? And if so, how do we go about this?
Yeah, you may be asked to collect specimens. Now, for that, you will be given, you'll ask for or be given, hopefully given without asking for, what's called an MEK kit. It's a medical examination kit, which has a large booklet in it and lots of plastic bags, slides, swabs, saline, everything you can think of, tweezers, scissors, the lot. And obviously you've got to take, if you're asked to take specimens, you take specimens that are relevant to the case. Now, if you're asked to take specimens from, the booklet is generic the booklet contains every sort of examination you'd be likely to do. So that if you're asked, for example, to take some hair samples and, say, a wet swab and a dry swab of a bite mark in the centre of the back, well, you would cut those with gloves on, put them into the various containers that they've got there, mark it in the MEK book. There's a consent part there as well. Mark it in that, seal it, put it in the other envelope, seal it, sign it across that, and give it to the police officer concerned. That's called chain of evidence.
And the police officer is with you?
The police officer will be with us. If not, it'll be a female. If it's a female, it'll be a female police officer. But, you know, again, common sense prevails, and the old idea of saying, well, you're not a very thorough doctor because you didn't fill in the blood pressure or you didn't fill in page 53, that doesn't work much more. But I just suggest if you're not doing things, just put a line through them to say that you actually noticed them. But I think taking a sample of pubic hair from someone who's the question is having a bite on the back of their neck is really not relevant, and it's just a nonsense. So just do your examinations that are specific. We are, in fact, turning out a much smaller limited kit for smaller limited examinations, and that is something that's on the horizon at this point in time.
If anyone listening wants to explore the idea of becoming a police medical officer, how do they go about it? And do they need the master's qualification that you've got?
No, not at all. There's two other people doing forensic medicine in the country who have a master's, and there's 3 ladies who are doing sexual assault who have a master's degree, and all 5 of us are fellows of the Australasian College of Pathologists as well. No, you can just do a paper out of interest, but if you were keen, we are always very keen. We are always looking for people. You would contact either me, and my contact details will come in here later, but you either contact me or your local police district commander, and they will put you on to the appropriate person.
Now, you mentioned earlier that part of your salary with the police is to advise doctors in doing statements, as well as teaching groups on police medicine and forensics. So how do people get in contact with you?
Well, I'm pretty easy. I have a cell phone on me all the time. That's 0274 88 888 1. That's 0274 and then 5 8s and a 1. Or you can contact me at lowercase jd.em, that's Juliet Delta dot Echo Mike dot Drummond, DRUMMOND, at extra.co.nz.
Thank you very much, Dr. Jack Drummond, for your time and expertise today. It is reassuring to know that there is someone we can call for advice on statement writing and to help prevent us from making mistakes if we ever get called to court to give evidence.
Well, you're very welcome. Everyone's allowed to make mistakes. There aren't any new ones. We've all made them. And you're allowed to have a dry mouth after you've come out of court.
Right, so that was Dr. Jack Drummond, and my take home from that, Dave, was he is available for advice 24/7 if you have any issues relating to dealing with police cases, writing statements, or anything that might go to court, and either by email or even his cell phone. So that's quite reassuring because it doesn't happen that often. We see a lot of people who are in alleged assaults and police-related things, but it's not that often we actually then have to do a statement. But when you do, it's quite nice to know there's somebody you can contact. And it was also nice to know that it's okay to take photos as an aide-memoire. That was something I wasn't aware of before then. Do you have anything to say on dealing with police cases?
Yes, when I used to work in the ED, we had to do a lot of statements of evidence, and thankfully, since working in the community, that's a much less frequent occurrence. And I think his opening statement, where he says, the better job you do in writing up your account, the less likely you are to go to court. And that's probably the thing to take home from the entire thing. So it's probably good to write yourself a draft email with or draft document with elements that you want to include, and little aids, memoir, as well as photographs. And if you see a case that you retrospectively have to do a brief of evidence, then refer to that. If you know that it's going to likely do that, I would probably start the document as soon as you can. But of course, the question is, where do you save these? So it's probably good to have a file that you can put these in. And so otherwise, everything that he said was really excellent. And I think he talks a lot about things to do and things not to do, and tricks. And I've only ever been to court twice, once at Auckland Court and once in Otahuhu. And certainly I did experience the dry mouth and sweaty palm during and afterwards. And at least you no longer have to speak in that extremely slow, enunciating voice for the stenographers anymore. Obviously, technology is caught up. And the things that he said when you listen to it, the defining things as abrasions and bites, and writing as much lay language as possible is also a good idea. And you can put your medical terms in, but as long as you define what they are. But other than that, it was a great, and I didn't know that it was someone I could call to help out.
Yeah, exactly. That was the thing that I took home most from that, is that there's somebody who can keep us on track and make sure, particularly if it's the first time, or if you're in a small clinic with no one who's been to court or had your experience in ED doing statements, it's nice that there's somebody you can call or email. So yeah, that was Dr. Jack Drummond, so thank you to him. And we now move to the nurses station, and I caught up again this time with Amor, and we talked about removing casts safely, and we'll listen to that now, and we'll have a chat in a second. Right, so welcome back to the nurses station. Today I am joined again by Amor Kisling, nurse practitioner in urgent care. Thank you for joining us again, Amor.
Thank you.
Now, we've chosen a topic today similar to the previous nurses station, that is relevant to nurses, but is also actually highly relevant to doctors as well. And that's the use of a plaster saw or plaster shears in removing plaster casts. So it is normally a job that falls to the nurses to do, which is why we're covering it here. But there has been studies done which show that actually doctors are not the best at doing this. So highlighting how to do it for our doctors is important. There was a study last year in the Journal of Bone and Joint Surgery of America where they put their surgical orthopedic residents through a training simulation program for removing casts, and it had a big reduction in cast saw injuries. So it's certainly a relevant thing for our doctors to listen to. So let's just start with the tools that we might use for removing a cast. So we've got the shears and the blade. So what about the shears?
So the shears are normally used for unpadded cast or bloodstained cast, blood-soaked padding, when the material is quite thick, when the cast is wet, on delicate skin, when there's any swelling or concerns, when there's pins and wires that's in the cast, or for really large casts. That's where we're using shears. And
they sometimes reference that you can use these if you're dealing with a patient who is very much afraid of the noise of a plaster saw, because the plaster saw is obviously the other tool. Now, it's important with both of these tools that they are properly serviced and that they are maintained in a proper way. So we've got the sharpness of both the shears and the blade, and they've got to be properly serviced in the case of the machine bits of the plaster saw, and the vacuums that are attached all have to be properly cleaned out, etc. So preparation by having the right tools for the right job. Plaster saws have different blades for different materials as well, so it's important that you check your material and check your equipment rather before you start doing anything with the patient. So you've checked everything, and your patient is then there in front of you. The first thing you obviously have to do is explain to your patient what you're going to do. So what are the important things to explain?
So it's important to explain what you're doing, which instrument you're going to be using. Especially if you're going to use the electric plaster saw, that it's going to be noisy. They can feel vibration, and also explain that the possible cautions, it can cause a bit of burning and some abrasion. So if the patient feels any discomfort or any pain, they need to tell you immediately. Also that the patient need to sit quite still. So you need to look at if they can hold the limb really still, and just also offer some ear protection as well.
Yeah, I've read one study that looked at the noises, and they found that it wasn't occupational levels of noise, but that it isn't a really annoying noise, and particularly children find it quite annoying. So putting ear protection on helps to calm people down, and certainly is a very sensible thing to offer to people. So you've got the patient nice and calm and prepared, and you've explained to them to tell you to stop at any point, and it's important to exude an element of calm and collection. You shouldn't rush this. The patient will not appreciate that. Now, if you're using the saw, one thing I often do is show on my hand that it doesn't cut. The oscillating saw doesn't cut, because that often allays some fears that people think that it's going to cut them. So you've got them all nice and prepared now. What do you then do to decide where you're cutting?
So you're looking at the cast and where you want to cut, then you draw a line. So you'll be avoiding any wounds, any bony prominences, any concavities. Also, again, if the cast is wet or blood-stained, blood-soaked, then you can't use the electric saw. But then after you've drawn your line, avoiding all the other things that I've mentioned before, we do use a plaster ruler, which you can then slide under the line that you've drawn, and then you start cutting with the correct cutting technique, which is in and out and rotating the blade, allowing for it to cool.
Okay, so what do you mean by in and out? What's your when you say that? How would you describe that over the?
So you start by making a cut where you go through the fiberglass, and then you stop. And every about centimetre that you progress, you take it out and you turn it, and you continue on like that. And it's slow. Do not try and do it fast. And this also, when you do a little bit at a time, take it out, let it cool down. It'll reduce it getting too hot.
Yeah, I've read somewhere that they would prefer to refer to this rather than cutting the cast off, but you're perforating the cast off. So it's almost like around the edge of a stamp. You're just making lots of little holes, which then result in the cast splitting open, rather than what people might imagine like a table saw or an angle grinder, and you're just starting at one end and you're just going along and unzipping it. So you are very much going in at 90 degrees, in and out, and then, as you say, rotate the blade and then in and out. And you mentioned letting it cool, because one of the biggest complications of removal of plaster saws are thermal burns, thermal injuries. These blades can get incredibly hot, and that transmits through to the skin. So that goes back again to, if the patient complains that it's too hot, listen and stop. So just taking the blade out will allow it to cool. Is there anything you can do to cool it a bit faster if you are in a bit of a rush?
Yeah, you can use a bit of water or just a bit of alcohol or alcohol wipe, and also just make sure that you touch it with your hand to make sure that it is cool before you use it again.
Yeah, there was a study published in the Journal of Pediatric Orthopedics in 2014 that looked at various ways. They found that actually having a plaster saw vacuum attached helped to cool because of the airflow. They used 70% isopropyl alcohol to cool it, and also just water, and they found that all three measures reduce the cooling time. So certainly that's something that you can do if you're wanting to speed up that process, because the heat is the major injury causer. So once you've removed it, and you then use some splitters once you've cut it, you then use some splitters to open the cast up a little bit, don't you? What do you have to be careful for then?
So when you put the spreaders in, you've just got to be careful that you do not nick or get the patient's skin involved. Usually you need to put it in just above the padding and the sock that's underneath. Make sure that before you spread it open, you ask the patient if it's painful. If not, that you can spread it, and this will also break any little bits of fiberglass that you didn't cut completely through with the saw.
Yeah, and it is possible in some instances to make one cut and to open the cast up and somebody to remove their hand, but it is better usually to bivalve it with a cut on both sides to remove it, like two halves of an Easter egg. But there is a temptation to maybe try and force it open, and if you're doing that and it closes, you can nip skin in between the plaster, so you've got to be very careful. And again, that's a rushing thing. If you're rushing to do it in one go rather than two, then that's when accidents happen and injuries happen. And then once you've got the cast off, it's obviously important just to inspect the skin, because skin will get dry and a bit irritant. Some people get a bit of dermatitis, but it's always good practice just to document there is no injury, and if there has been a little bit of something, then address it then with the patient, because again, you'll have talked to them about it before, they'll have consented to you doing this, so it's important to check and be mindful of any injuries that might be there. So the complications, as we mentioned, the thermal burns, there was a study again in the Journal of Pediatric Orthopedics in 2016, and they found that they listed dull blades cutting into concavities when the padding is too thin or if the cast is too thick. So these are things that lead to too much heat and potential thermal burns. So that then actually goes back to when you're putting the cast on. If you don't get it right, then you're just making a problem for future you down the line when you're taking it off. So being mindful when you're actually putting casts on to get the right thickness and the right amount of padding will save you some hassle at a later date, certainly.
Yeah, so I just want to add a bit onto the caution. So just a couple of things to remember. The saw can get quite hot if you use it for a long time, if the cast is too thick, as you said, especially with long casts. So for instance, above knee cast, you've got to make sure that you know this will get hot, so make sure to give it a good rest. And also, if you've just done a cast and the resin hasn't set completely, it actually will make the blade a bit more hot if you use it to take it off to have to redo a cast.
Yeah, they do reference then, if you've put the cast on and it's wrong and you think it might not have fully cured yet, it's probably better at that stage to cut it off with the shears rather than the blade, because it does add to it. Certainly having a clean blade before, we mentioned having a sharp blade, but also if you've got any material stuck to the blade, that adds extra friction. And it's also good practice, isn't it, just to make sure the blade is clean. You know, if it's been sitting around outside, we want it to maybe have a bit of a wash before.
Yeah, give it a good wipe. We use toughies in our clinic. Give it a good wipe before you use it and after you've used it, because you're using it on different patients. So it's just good practice to use whatever cleaner you've got in your clinic or urgent care. Before patient, give it a wipe. After you've used it, give it a wipe as well.
So in summary, be prepared, have the right tool, choose the right tool, explain to the patient, map out where you're going, choose the right place to go slowly, don't rush, avoid overheating, listen to your patient if it's getting hot or uncomfortable, and inspect the skin afterwards to make sure that everything is fine. So any doctors listening, make sure you don't just pick up the sore and cut it off as if you're cutting a bit of metal off a bit of roofing tin. You've got to go at this slowly and not rush it, because, as I mentioned, that Journal of Pediatric Orthopedics in 2016, they quoted 0.1 to 0.7% iatrogenic cast sore injury rates. So that's getting up to approaching 1%. So that's all avoidable if you take your time. So anything else to add? Nothing else we've missed, I think.
No, I think that's it.
So thank you, Amor, for joining us again, and as always, we appreciate your input.
You're welcome.
And we'll be back next month with another episode of the Nurses Station. If anybody listening is interested in contributing, or if you have a nurse in your clinic who would like to be involved, then please email the podcast at podcast@rnzcuc.org.nz. Amor's kindly stepping in the last 2 times, and happy to have her back anytime, but it is open to anyone to contribute. So let us know, but we'll see you again next month. Okay, so removing casts, Dave, it's something that often falls to the nurses, but I know that when time is tight, doctors will often pick up a plaster saw or shears and go at it. And it's important that they realise that you can cause injuries and it can be an unpleasant experience for people. So I think it's important that they just follow some of the tips that we went through there, particularly going slow and explaining to the patient and making sure that blade doesn't get too hot. And obviously the clinics need to make sure that the equipment is in good order, so the shears are sharp and the blades are sharp and everything is maintained. What are your thoughts on cast removal? Do you have any?
So from my point of view, the safest way to remove a cast is to not have me do it and
Right.
to have the nurse
Yes.
do it. I quite often remove back slabs, and I have been caught out a couple of times with the shears, and obviously always have the sharp bit pointed away from the skin. And I've also had to review burns from incorrect use of plaster saw, one that was an above elbow cast that went all the way from the hand right up to the elbow with a significant scar afterwards. And it's always a fairly difficult thing to talk to parents about that afterwards. So I think that going through those hints quite carefully is a good idea. And perhaps if you do get a chance to play with casts, if the nurses are doing cast training, perhaps you could lend a hand by doing some cast removal training at the same time. And that's probably a good way to keep up your skills.
That's a good idea, to practice on somebody else. But really, it's all about going slowly, because if you try and rush it, the blade gets hot and then you cause burns, and it's not a good look. So take your time if you end up doing those. So now we move to the email section. Now, we've had some email feedback relating to our urgent bites that went out over the last few weeks. And we'll start, Dave, with the non-steroidal anti-inflammatory urgent bite. So the use of NSAIDs and fractures, and the animal studies that suggest that it impedes fracture union due to its effect on COX-1 and 2 and prostaglandins and the like, but that the human evidence hasn't really fallen in line. And certainly my understanding has been a short course of anti-inflammatories is acceptable in the first stages, but we've had a couple of emails which have raised the question of whether or not using the NSAIDs in the early part of the fracture healing can cause problems with hematoma formation. We've had Dr. Houston from Dunedin commented that their policy down there is to not use it for the first 2 weeks. Their understanding is that it can remove hematoma around the fracture, which contains some of the healing components, and lead to delayed healing, so they don't use it in that first 2 weeks. That's contrary to what I found in the reading there, and that's you're the same, aren't you? You feel the first few weeks is the time to use them.
Yes, so I've come across this time and time again, and I actually have phoned orthopedic surgeons on a few occasions just to double check. And really, there is no scientific evidence that doesn't involve beagles that suggests that bone healing is impaired with simple fractures with use of anti-inflammatories. And usually most advice actually says that short-term use up to 2 weeks is definitely okay, and probably okay in other circumstances. I know that some of the orthopedic surgeons who are doing complex operative repairs sometimes have reservations, but that's not usually the fractures we're actually dealing with. So something that doesn't have metal wear in it and is not infected, there does not seem to be any reason to withhold anti-inflammatories. In children and in adults. Obviously, you have to obey the non-steroidal rules that you don't give them with significant renal impairment, not when they're on an ACE inhibitor and a diuretic, and not if they're allergic. So other than that, there doesn't seem to be a reason to withhold non-steroidals for fracture pain.
I think it's maybe a marker of checking if something is wrong, if somebody is still requiring analgesia at that 2-week mark. You've got that. Maybe should be a prompt to think, why are they hurting?
Yeah,
should we look into it? Is there a problem? And do you use them, for example, then in rib fractures, which obviously they take a bit longer to heal? People.
Well, yes, rib fractures can be very painful for weeks and weeks and weeks, and I do use them because you've only got so many options, and I'm more comfortable using an anti-inflammatory than a weak opiate for week on end, and I think there's probably less complications with doing that way. And I do follow the sort of analgesic ladder with your Panadol and anti-inflammatory, followed by your weak opiates, withdrawing the weak opiates as soon as you can. So that's my management technique, and I never really had too much of a problem with fracture rib healing. They seem to do well. Once in a blue moon they won't heal, and then there are other reasons for that usually.
Yeah, and that was referenced in one of those articles from the Bite, was that people who are still needing analgesia later on down the line, there's another reason probably why it's not healing, and it's not a causal thing that they're using the anti-inflammatories cause the non-healing. It's just coincidental. So yeah, certainly from those feedback emails, we can't find the evidence that would suggest to avoid them for those reasons, I guess is what we're saying. One of the other urgent bites was on catching MSUs in children, particularly those that can't void, the under 3s that can't void on demand. And what are your strategies around this? If you've used the dipstick, if you've used the urine bag to exclude a UTI, but it comes back positive, so you're now thinking we need to go on from here. BPAC guidelines would say you need an MSU to confirm it, and so how would you then go about catching a sample? What's your thoughts on that?
It is a challenge, and it's always the pediatric challenge, really. A clean catch of some description is required to diagnose a UTI in children, and I would almost never empirically treat without getting a sample, because it's important to get the correct diagnosis for their illness. I guess under some circumstances, such as someone that's been diagnosed with vesicoureteric reflux, that might be a useful thing to do. But almost always, you need to get a diagnosis with a clean catch, and so that could be clean catch in the clinic, clean catch with the parents, or referring to a service that can either get a clean catch, do an aspirate, or do a catheter. I personally don't do catheters in children because I'm not very good at it, and I know that there are pediatric nurses that are excellent at doing that. But I think it is important that main thing to take away is that a bagged urine can never diagnose a UTI, and it can be never used to culture a UTI.
It could just be used to exclude it.
Yes.
And even then, there's still that 3% chance of it being false positive. So you've got to always use your clinical judgment as well. So in terms of catching a sample from a child, that clean catch, it's a wait and see job, isn't it? And I think you forwarded me a piece on trying to get a child to urinate on demand.
The quick wee method.
Yes.
I can't remember it all off
No.
the top of my head, but it involves using a cold flannel to wipe the perineum, and another technique is to tap the bladder, and they tend to be very effective. But
Yes.
I know there's mixed results, and I think you need to be good at doing it, basically.
So I'll put that link in the show notes for that particular technique, because if you're deciding it's going to be an MSU, it could mean that the patient is waiting in clinic for a while, or going home with sensible parents with instructions to avoid the invasive referral to hospital for an invasive technique. So yeah, that it might be worth just having a read of that article that you forwarded. We'll move now to the news section, and the first news item was something I wanted to talk about in relation to an urgent bite. The first one was about the adrenaline use in CPR and the Paramedic 2 study, which is looking at the need for adrenaline in cardiac arrest and how it can affect outcomes. But there was a lovely story across all the media in America, actually. They all referred to this as the first kiss on a first date, and it was a story about an anaesthetist and this gentleman going on a first date paddleboarding somewhere in California, and as they're walking back up the beach, he collapses face down on the beach, and having had a cardiac arrest, and she flips into doctor mode and performs CPR, and 17 minutes later he gets a heart rhythm back, has surgery the next day, and they're now teaching the benefits of good early CPR to all sorts of different groups and sports groups. But the really cool thing was that there was a videographer who'd set up a camera on the beach filming some stop motion tidal photos, I think, and this man managed to collapse directly in the center of the frame, totally unknown to the videographer. So you can see a cardiac arrest happening as it kind of right in front of you. It's quite compelling to see, and sure enough, the media stopped the film just at the point she was delivering some breaths, and called it their first kiss on their first date, which was all about that was their angle to the story. But I thought it is a good demonstration of how good compressions, maintaining the airway and getting electricity as early as possible is the key thing, because this man had a very favourable outcome. He's now working and back to normal. So it was a nice story, I thought, to reference alongside that adrenaline study. So what were your thoughts, Dave?
Yeah, no, it was a great video to watch, actually, and it does highlight the fact that the only thing that we know for sure works is CPR, and that could be chest compression only CPR in the first 5 to 10 minutes, and certainly for bystanders, there is a lot of push for compression only CPR, which I'm quite happy with, unless you're drowning. The respirations are not going to be that important early on. And then early defibrillation. And the reason that the defibrillation eventually worked is that they managed to keep the person alive with good CPR. And there have been reported cases of people waking up and talking while dead, essentially, because the CPR is keeping them alive. They've got no actual natural heart rhythm. And so, yeah, what we need to teach, what we need to get everyone to do is compressions.
Yeah, and certainly in a urgent care clinic, if you, depending on staff, you might not have the resources there to say somebody takes the time to put in a line, and therefore you might divert attention away from doing the important things in favour of getting in a line to give a drug that may not make that difference. So certainly we should make sure we're doing good CPR first and get that electricity as soon as possible.
And not to interrupt CPR. That's the other.
Yeah, as minimal time off the patient as possible. So it's a nice video to watch. It's a nice story, and it's good to see a happy outcome. Another news article around the world I wanted to just talk about was the announcement of the new Apple Watch. That came with the usual ceremony that Apple seemed to manage to do. But buried in there somewhere, there was this new feature that the Apple Watch is going to have an ECG on it. So when you touch the bezel with your one hand and the watch is touching your other hand, you've then got two leads of an ECG. And they've got some kind of algorithm that will identify arrhythmias, including atrial fibrillation. And there are some concerns raised by some medical community that this may lead to a lot of false positives. And I guess in urgent care, we may get those people coming in saying, hey, doc, my watch told me I've got a heart problem. And that then feeds into the sort of the choosing wisely side of medicine, is when do we then believe somebody's watch and initiate lots of tests, potentially invasive and expensive tests, because the watch tells them that they're sick. So we may be getting people attending with their watch telling them they've got an irregular heart rhythm. So it could be a really compelling device, particularly if somebody is able to catch a rhythm that you're suspecting but you've not been able to catch in any other way. But we may face a few people being a bit more led up the garden path.
Yeah, so I guess one of the questions with that would be, how useful is the technology at being accurate? And then also, how's the data extracted? So if someone was to come into my clinic with an Apple Watch, I wouldn't have any way of downloading the information and printing it out and transferring it. And maybe it is useful, but maybe there should be a specialist interpretation unit that they can send this to, or I certainly would want a cardiologist interpreting the data. So it does open up yet another electronic minefield for us.
It's certainly one to watch going forwards, because, as I say, I can see us getting the odd question as this comes to fruition. And that leads into another case that was actually in the Herald, but it was from America, and it was this lady who'd used Dr. Google, as it's called, to identify a very rare condition, or she raised the possibility with her surgeon, who basically told her to stop using Google and was quite demeaning to her. And then it turned out that she was right. And I guess we mustn't fall into that trap of dismissing people and their concerns with if they've used Google, but it is also technology being available to people like the Apple Watch, but just the internet in general is a tricky one to get that balance right between listening to all that over information and also not being blasé and missing something and then being on the end of a complaint.
Yes, I think we do. We all get the Dr. Googles coming in, and it is very challenging, and it depends what the question's being asked. So she had a case of a very rare variant of endometriosis where she had extrauterine endometriosis, and we know that can actually occur. We don't know how it's spread throughout the body, but as far away as the eyeball, there have been reported cases, and of course, diagnosing these things is exceptionally difficult. And so I guess it's a cautionary tale to listen to everything that's said and analyze everything that's said, but don't believe everything that's said, but see if you can exclude an important diagnosis. Sometimes people will come in with a variety of questions, and sometimes it's very hard to be specific. I guess you just try your best to answer as much as you can.
Absolutely. Now, as I say, that was in the Herald, but it was an overseas story. But we moved now to some New Zealand stories. The first one I'd like to bring up was in Stuff, and it was a lady who'd had a thorn in her hand, and that went on to, as the headline says, the flesh-eating disease, a rose thorn nearly killed me. And this is an interesting story because it includes pictures of her hand as it evolved, and hand infections don't always look as bad as they are. I think that was my take home from this. I've seen pictures of intraoperative hand surgeries where the pre-op picture was just a small little red dot, but the hand was full of pus, and it's quite a good story that identifies how quickly and how bad these little thorn pricks can go bad. I don't know what your thoughts on that was.
So it was an excellent article, actually. And necrotizing fasciitis or flesh-eating bacteria is another one of those nightmares of medicine. And they don't look very dramatic because dead things don't get bright red. And so my take on the number of cases that I have seen of necrotizing fasciitis is pain out of proportion to the clinical findings and loss of function. You put those two things together and you should be thinking necrotizing fasciitis every time. Unfortunately, it won't be every time. Incidentally, I did email Mark Thomas from Infectious Diseases to discuss necrotizing fasciitis because I noticed that the health pathways didn't have a treatment regimen. And he said that his recommendation is 2 grams of flucloxacillin stat while you wait for the ambulance. But he's quite happy with St. John's protocol of Augmentin IV. So that's just a little gem that may not be in the standard guidelines. But again, pain out of proportion to what it looks like, always think necrotizing fasciitis. And, it could have been a splinter, it could have been a thorn, it could have been what's supposed to be a spider bite, even though that we know the spiders don't cause flesh-eating illness. The thorn is probably more likely than the spider to do that. So it's a good cautionary tale.
So again, the links are in the show notes. On a similar infective story, I just wanted to raise September was sepsis month around the world, and BPAC released a couple of months ago their new guidelines on early recognition of sepsis, and they have done that in collaboration with the National Institute of Clinical Excellence. And there'll be a link in the show notes, but it's quite a lengthy document, this, to read through. What I'd encourage people to do is to follow the link to the NICE guidelines and find their 3 algorithms, which are a page each and are a little bit easier, because early sepsis can be quite difficult to identify. And I think in urgent care we fall between 2 stools sometimes of people aren't sick enough to go to hospital, so they come to us, but they might be getting sick, and we don't want to be left holding the bomb when it goes off if we've sent them home without decent safety netting, and also having documented all the things that we need to show that we've thought about sepsis and covered all the bases. So it's a good thing to read through, but the NICE guidelines have the algorithm that makes it a little bit more digestible. But, what are your thoughts on early sepsis, Dave?
So yeah, early sepsis is really tough, and there's a good and extensive guideline there. I'd remind everyone to think about your news score, the early warning signs for serious illness, and sepsis is just one of those. But if you've got quite significantly abnormal physiological parameters or observations, and especially in association with a decreased level of consciousness, then you should be having alarm bells ringing on your head and thinking, even if you don't recognize the sepsis, maybe they're hypothermic in an elderly patient, not feverish, then you should be calling for help and referring it in. But it can be very challenging. And when I see my patients and I'm not sure, but they seem to be okay, I'll always say, always 3 things happen in life. You get better, you get worse, or you stay the same.
Yeah. And
so I give them advice always as to what to do if things are getting worse, and when to call the ambulance, when to be extremely worried.
Yeah, I think that the safety netting is important, because it was sepsis month rather. There were a lot of cases around the world of stories of sepsis, and when you read those, any criticisms of the healthcare community were often based around false reassurance. So I saw my doctor and he said I was okay and I went home, and they sat at home getting worse in the belief that they were okay. And I think it's important to say, whilst I think you're okay to go home now, if you're getting worse, you must get reviewed. They shouldn't feel falsely reassured such that they stay at home. So having those safety nets are important to avoid negative outcomes. So that's certainly worth the read. The final story, again, was from Stuff just today, actually, and that relates to a rower who received intravenous antibiotics for infected blisters, and he was an elite rower, and he also received the Probenecid as part of that protocol. and Probenecid is on the banned substance list for sporting elite sports people. So I guess this just highlights for us the being aware of which drugs are on those lists, and if you suspect someone is, or if you know someone is an athlete, raising that question to them of, are you being tested at the moment? It's also, though, does fall on the athlete to tell you. I think there is a bit of give and take here in these situations, but I think as clinicians we've got to be aware of it and know where we can get information on from the WADA and all those local drug agencies. So yeah, we need to be aware of it, but there is also, I think the patient has to tell us also, because they know they're an athlete and they know what they're doing. So if they're going to take a drug, they need to put their hand up and say, is this safe? But what were your thoughts on?
It's definitely a shared responsibility, and I mean the two drugs, I guess, that are the most common ones are Probenecid and prednisone. So when you're prescribing those two, it doesn't take too long to say, "Are you an elite athlete?" Have phone numbers on your wall at work to who to call to getting a therapeutic exemption or other people to call. But we're very blasé about using those two drugs. We use them so often, but you've got to always remember in your back of your mind, this is a career-defining moment in an elite athlete. So I better just double check. But yes, it is a shared responsibility. Yeah. And it's all about just making sure, I guess, sometimes.
Yeah, so again, all of these cases will be in the show notes, so people can have a little read and go through things. Now, if we move on to college news, last month we had the college dinner, which was the inaugural fellowship presentation and unveiling of the coat of arms. Afraz talked about it in the last podcast. That was a very enjoyable evening. I think the crest looks great, the coat of arms looks great, the new fellowship certificates look great. Now, Afraz has been over in Ireland and he's been meeting up with some Irish doctors who are sitting exams later in November. What can you say about that?
So yes, we've all in the office been receiving lots of photographs of Afraz's travel, and it's great for him to reach out and take the time to meet those three registrars who will be coming all the way across to sit the exams in November. And I think it's interesting because it highlights the fact that this type of medicine is very useful, but so few countries in the world actually have it available. We all know that emergency departments are overflowing everywhere, and it's in the news everywhere. So it's good to have it somewhere else. Obviously, we're not big enough to do the whole world, but at least we've got Ireland under control. In other news, of course, the website was launched when the dinner was launched, and that's being gradually upgraded. The social media, podcasts, etc., will be on the website, as well as social media news from medicine, as well as the Facebook. So we're trying to make sure that it actually comes from our website first. So you don't have to be a Facebook reader to read the little blogs that I put in about medical news. Obviously, for those of you who are sitting the exam this year, it's on the 16th and 17th of November. The written will be on the Friday and the OSCE will be on the Saturday. If you want more information about that, you can refer to the website.
Yeah, I think the website looks great. It's very easy to use. It's full of information, and yeah, it's a good improvement. On a note on the podcast, we're now able to be listened to through Spotify. We've got enough content now that Spotify have accepted us onto their streaming services. We're also listenable through YouTube, and most podcast apps seem to be finding us. So if you use a podcast app that doesn't find us, let me know and I can try and get us linked into then. We've had listens from all over the world. It's been amazing watching the statistics come in. We've had people in Singapore, Malaysia, Taiwan, Sweden, Norway, Germany, Croatia, where else has there been? The UK and Ireland, obviously. So those registrars have obviously been checking in. We've had USA, Canada, and Australia, as well as a large number from New Zealand. The bulk is local, but it certainly has been getting out there. So hopefully that will continue to grow. And I would encourage anybody to contact us. We've had some emails this week or this month on some of the urgent bites. And yeah, if people send us their information, we can discuss it. We can take advice. We can take volunteers who want to appear on the podcast. So I'm keen for people to get engaged and just use this as an opportunity to share ideas with peers and to just to reach out to literally around the world. There are people all over this world listening to this. So advancing urgent care is the plan. So I think that's all for this week, Dave. Thank you for being here again. We'll await and see who's going to join us next month. But next week there will be an urgent bite, and it'll be slightly different to the last lot. I'm sitting down next week with a sports physician who's going to contribute to an urgent bite. So we're trying to get a few things, just change things up a bit, so it's always different and always interesting. So look out for the urgent bites next week and every Friday until a month's time, when we'll be back for episode 3. So thank you, Dave, and we'll see you next time.
Thanks for having me.
That's great. Thanks for listening. The information discussed in this podcast was intended for the ongoing professional development of qualified health professionals and should not be used for self-diagnosis. For any personal medical concerns, please consult your usual doctor.